wasn't big, about the size of a lemon, but thankfully it was already in the small colon and working its way out. It may or may not have stayed as a paperweight in my office for a while. More commonly though, enteroliths are stuck and the colic just doesn't progress. In areas and regions where they are common, practitioners will use a radiograph because that is a great way to identify them in the abdomen. Other intra-abdominal masses, they can come from anywhere, like the lipoma or ovaries or hematomas. And depending on where they are, they can affect the intestine in different ways too. The rectal exam tells you a lot of information about the intestinal tract, and then the nasogastric intubation tells you a lot more information about the proximal intestinal tract. If you have a sour smell, the food has been stagnating and you can confidently say there's delayed gastric emptying. If there's reflux, there's an excess in biliary fluid that's being produced and it's unable to move through the intestine normally. This doesn't necessarily mean that it's a surgical obstruction because ileus can cause this too. But if you get more than 4 liters of reflux, or if the reflux is continuing despite the being off feed and being treated, you have some sort of outflow obstruction. If you add to it the presence of severe colic signs, you're likely dealing with a small intestinal strangulation. If instead you have some systemic depression or a fever, you might be dealing with a functional ileus. We now have a great tool that gives us information up to 30 centimeters deep from the sides of the abdomen, and that's the ultrasound. The focused localized abdominal sonography of horses, also known as flash exam, has been developed to give a good overview of key areas that are potentially involved in a colic without requiring a lot of time or a lot of skill. A more detailed presentation will cover the flash exam in detail, but we're going to go over some of the key views here. I like to start my exam either over the left dorsal flank or the ventral midline, and you can start wherever as long as you do a really systematic approach. For simplicity's sake, let's follow this diagram here below, and we're going to start on the ventral midline. We're going to look for free fluid, and then we're going to move cranial towards the lungs, looking for pleural effusion or any other abnormalities. As we go a little bit more caudal, we'll see the caudal greater curvature of the stomach against the spleen, and then we'll have the spleen and the kidney, which is what I call the money shot, looking for your nephrosplenic entrapment. The spleen will also be sitting up against the saculations of the colon and will indicate if there's any in colon abnormalities or small intestinal entrapment. And then if you want to look at the small intestine more, the inguinal regions just in front of the stifles on the right and the left are really good places to look for small intestine. On the right side, you're going to see in the dorsal flank the cecum, and you're going to do mural measurements to see if there's any thickening or if there's any edema. And then as you move forward, we have the duodenum that sits just in front of the kidney, between the kidney and the colon, and then a little bit further cranial between the liver and the colon. Sit here for a few moments and you'll be able to watch the duodenum move in a very rhythmic pattern. Sedation might slow this down, but it gives you a good idea as to how well the peristalsis of the proximal intestine is working. Then I like to finish my examination in the right cranial abdomen, and this is just tucked underneath the lungs, where I can look at the right dorsal colon for any edema, colon swelling, signs of peritonitis, or even in the cranial ventral lung field for fluid and signs of pneumonia. This is the flash exam. It's a really fast overview, so be sure to take your time. You can record your findings with screen clips, and you can do captures or notes and then look back on them later.